Hey, good evening. This is Peter Schneider, San Francisco. We have Sahil Parikh in New York and Mike Siah in Dallas. And we wanted to do this brief program tonight, partly because we're really excited about the kind of the developments in this space of vessel prep and the use of Serranator as well as other tools. So we've got some cases lined up, and of course, Mike Siah, professor at UT Southwestern in Dallas, and Sahil Parikh, professor at Columbia University, two absolutely top-notch interventionists in this space. So we're fortunate to have you guys. And I just wanted to kick off the discussion. The thing that kind of got us interested here about Serranator and the things we're going to talk about tonight is really about vessel prep. And I wanted to, Sahil Parikh is a cardiologist, and of course, cardiologists knew about vessel prep long before us everyday vascular only people really knew about it, thought about it, worried about it. So, Sahil, maybe you could give the audience just some thoughts that go through your head when you think of vessel prep and what it includes and that sort of thing.
Well, Peter, as you know, coronary intervention is easy because you finish every case with a drug-eluting stent, whereas we have a menu of options. But really, I think as we've learned in coronary intervention, in order to get adequate drug delivery, whether it's a stent or a drug-coated balloon, we need to prepare the vessel and really do the work of the intervention. In other words, improving the luminal gain before we come in and paint the lining of the vessel with a drug or implant a stent, which has to expand completely. And so the prep has become, paramount in all circulations, really because drug delivery technologies have become the dominant mode of treatment. That even if you're not going to use a drug, getting adequate luminal gain is important because that dictates your, net gain after you have late loss from whatever restenosis process you get. But, truthfully, I think it's only become more important as we've tried to find ways to deliver drug. And so for the FemPop specifically, and also now for the below knee circulation, if we're not getting adequate vessel prep, we're not going to get optimal results no matter what technology we follow with.
Yeah, and I'm wondering, so something you said, Sahil, caught my ear, and that is that I think when I first really started to understand the value of vessel prep was when drug-coated balloons were introduced into the non-coronary arteries. That is, the whole drug delivery concept is sort of a non-starter without excellent vessel prep. And I know Michael, as a rising star but newer uh, clinician in this area, your career has kind of paralleled or been kind of concomitant with the rise of vessel prep in the periphery. So give us your take, as somebody whose career now has kind of grown up with and been at, kind of at the same time as the rise of the use of, or at least all of our thinking and all of our planning when we do peripheral cases. When can we do vessel, drug delivery, et cetera? What do you think?
Um, I'd like to echo what Sahil said. I think anytime you think about treating the femoral popliteal area, you have to not only think about treating these patients mechanically with a balloon or vessel prep, and then chemically, just because we know chemical treatments do better than treatments without chemical. And up until very, very recently, we haven't had the ability to do that below the knee. So I think that my interest in using specialty balloons below the knee simply comes from the fact that prior to having the new PRS, we we only had conventional angioplasty, and I think the limitations of angioplasty are what a lot of people have sought to overcome. So when I'm treating the SFA popliteal area, I'm always thinking about optimizing that vessel for drug uptake, and now I get to think about it in the same way below the knee.
Yeah, it makes a lot of sense. And before we jump into the cases, let me just get your opinion on one other thing, and that is there's been a lot of talk uh, about plaque modification versus debulking. And I don't know, is that two different things? Is that the same thing? And how should we be thinking about it in terms of, in terms of the end goal, which is to create a terrific lumen that is lumen gain with a smooth surface, so that is minimizing dissection. And how can we, prepare again for if there is a drug option, prepare for that. So what do you think, Sahil?
Yeah, so Peter, those euphemisms were invented for coronary atherectomy. So the original term plaque modification, specifically in the coronary circulation, was when you were trying to really debulk lesions optimally, whether it was with directional atherectomy or with rotational or whatever technology, you're trying to really cut out as much plaque as possible. And then the randomized data showed that that was, more complicated and not any more effective. So then it became a strategy of plaque modification, i.e. vessel compliance changing. And so the idea was, don't drill the crap out of the artery. Just do it a little bit so that you can, make it expand, particularly because you're going to stent it anyway. And so that was sort of the difference. Now, very interestingly, just recently, a couple of weeks ago at TCT, there was a huge randomized trial called the Eclipse trial that compared orbital to balloon angioplasty in heavily calcified vessels. And it showed no difference in acute outcomes when you're using stents. So the whole concept, even of plaque modification, is sort of in question in the coronary circulation. And it's not so much that it doesn't work, it's that you pay a price in terms of complications, embolic and otherwise, when you try to use more complicated technologies. So, it certainly leaves open the question about what's the right way to achieve vessel compliance. And I think that's particularly relevant when you're trying maybe to leave no stents behind, no metal behind. And so, again, I think it gets us back to this idea, how do we prepare the vessel to make it compliant without doing too much?
Yeah, that makes sense. So we've got in terms of tools that we can use for vessel prep, we could use plain balloon, and that, of course, the IFU for all the initial DCBs for SFA, all the trials were done with plain balloon. We also could use a modified balloon like Serranator. We also could use atherectomy, et cetera. So obviously decisions to be made. We don't have all the data for all the scenarios, but we certainly have some good cases to show. Maybe we could jump in, Michael. I think you were going to talk about Serranator a little bit and the mechanism of action. Why don't you go ahead and share your slides? And while you're doing that and getting ready for that, I'll just say there are a lot of people on the webinar right now. I'm keeping an eye on the chat. Don't know if I'll be able to answer your questions, but I'll do my best. And don't hesitate to jump in if one of us says something that could benefit from a follow-up. And Michael, why don't you go ahead whenever you're ready?
Yeah, so we pull up those slides. So it's just a nice overview slide of the Serranator angioplasty balloon or aspiration balloon catheter. I think when I think of this technology, I've thought about it for a long time when it comes to below the knee blood vessels, and the diameters available 253, 354. Those are the mainstays that I've used for the past several years in treating my BTK vessels. And more recently, the 5.0 and the 6.0 have become available to treat the popliteal and the SFA. I think they're all pretty much compatible with 5 and 6 French sheaths. All of them will go through a 6 French sheath. The smaller sizes will go through a 5 French sheath. And for the most part, they're all compatible with 014 and 018 wires. You go to the next slide. I think the differentiating factor when it comes to Serranator fundamentally is associated with how we've taken an industrial application and applied it to something we use within the body. And that's the application of these linear stainless steel serration strips which essentially act like individual stilettos. These individual points are able to provide a lot more force, 1,000 times the point force compared to conventional angioplasty, along these linear strips, which I think allows you to get very predictable results using low and slow inflations. And I think that allows for you to get very, very, consistent results that mitigate the risk of recoil and dissection. You go to the next slide. This is just a nice image showing the ways in which those points on the serration strips apply that force along the entire length of the treatment area. And you can see pre and post Serranator IVUS images where you can actually see the effect of the linear strips on that intimal calcification, medial calcification. Go to the next slide. So this is one of my cases that I did relatively recently. It's a 52-year-old patient with a left hallux ulceration. They'd previously undergone a right below-knee amputation and a host of other cardiovascular-related interventions, as well as dialysis access creation. And like so many of these patients with critical limb-threatening ischemia, non-compressible ankle brachial index with a toe pressure of 26 millimeters of mercury. So I see something like this, I know this patient needs to get at minimum an arteriogram just to assess what the next best thing is for the patient. You know, the next slide. So this patient had pretty mild superficial femoral artery disease, but you can see a focal high-grade stenosis of the P2 segment of the popliteal. And then a pretty interesting appearance of the tibioperineal trunk into the posterior tibial artery. The PT is the dominant runoff to the foot, and you can see high-grade stenosis of that medial plantar artery below the ankle. So we have popliteal disease, we have TP trunk, proximal posterior tibial artery disease, and then we have plantar disease. So you go to the next slide. This patient also was like 6'7", so very tall. So I usually get up and over access and go up and over. So that's one of the big limitations to a lot of the technologies that I use, especially if I have to intervene below the ankle. So the first thing I did was I crossed these stenoses, got a wire all the way beyond the stenosis in the foot, and then used IVUS to better ascertain the luminal diameters of the posterior tibial artery, the popliteal artery, and the PT in the mid portion was 4 millimeters in diameter. So I used a 2.0 balloon to treat that medial plantar artery, and then followed that up with a 4.0 120 Serranator to treat the posterior tibial artery and to pre-treat or vessel prep that SFA popliteal lesion. Go to the next slide. I follow this up in the popliteal with a 6x150 Ranger DCB. And then the next slide. You can see a nice technical result of the treatment of that SFA popliteal lesion and a little haziness and residual stenosis in that tibioperineal trunk. And I thought that this was a great opportunity to use an Esprit bioresorbable scaffold to supplement the therapy that I delivered in that TP trunk. You go to the next slide. So we used a 3.75 by 38 Esprit, taken to 4 millimeters in diameter, and our completion angiogram. So nice technical result of that area, and more importantly, some brisk flow all the way out through those plantars to the hallux. I think that's a nice technical result. And, I expect after this patient to go on and get a good outcome. They may need a, hallux amputation, but I think, or partial hallux amputation, but I think they'll go on to get some good limb salvage here. We go to the next case. Next. So just go on to the next case. This is an 83-year-old patient with a left plantar ulceration, classic comorbidities, including heart failure with an ejection fraction of only 30%, with no previous lower extremity interventions. And again, non-compressible ABIs with a toe pressure 27 millimeters of mercury on the affected extremity. Next slide. So this time the patient's popliteal is totally fine. But the tibials are a lot more diffusely diseased. We see an occlusion of the anterior tibial artery, a pretty ratty perineal artery, and reconstitution of a posterior tibial artery that's pretty diseased all the way down to the malleolus. So given the location of the ulceration being on the plantar aspect of the foot, tried to pursue a posterior tibial artery revascularization. You can go to the next slide. So once again, you can play the video on the right. So this is a simultaneous pullback of the IVUS and the IVUS in that posterior tibial artery. And we measured 3 millimeters distally in the posterior tibial artery and 3.5 more proximally. And you can just see that 360-degree eccentric calcific disease that's affecting that posterior tibial artery. You can go to the next slide. So this is a patient, also is pretty tall, ended up needing to use one of the 170 shafted tapered balloons to treat that distal posterior tibial artery. But in the mid portion of the posterior tibial artery, did use a 3.5 by 120 and use that again to treat the proximal portion of the posterior tibial artery. We go to the next slide. We can see here, I think, a very nice result of that posterior tibial artery after serenation angioplasty. But knowing what we know and having the tools we have available to us, there's a great opportunity to use these 2 Esprit scaffolds, but using it in sort of my own type of way, you know, in the clinical trial, Sahil, you probably talk about this, you know, this was an enrollable lesion. We'd have to cover everything with scaffolds, but I think in the real world, that may be challenging just from a cost perspective. So I figured sort of treating the 2 bookends of the lesion with 2 different sizes sprees, one more proximally and one distally. We go to the next slide. And I think with a very satisfactory result in the treatment area with great flow all the way out to the plantar aspect of the foot and wound blush. Go to the next slide. And those are 2 of my cases.
There's a lot to comment on there. But Michael, why don't you rest your voice for 1 minute? And let me just ask Sahil. So Sahil, you were the senior author on the Life BTK randomized controlled trial. And maybe you could comment on the importance of vessel prep for getting good results with DRS, since you're the leader of that.
Yeah, I mean, field. Peter, absolutely. You know, well, all of us that have been working on the team to help with the trial, we were clearly aware of prior experiences with the first generation Absorb. We knew from the coronary experience that vessel prep was sort of critical, and there was a algorithm, the PSP algorithm, you know, pre-dilate aggressively, size properly, and then post-dilate aggressively. That was sort of the ticket to getting good results, particularly in long segment disease, especially in small caliber vessels, which is basically describing every tibial that we treat. So specifically for the Life BTK trial, heavy calcium was excluded. So, you know, Mike, even though these cases were probably includable, the target lesion lengths were less than 17 centimeters, but calcium was, you know, in the main really excluded from the trial. We had sort of mild or moderate at most calcium. And many of the treatments that we deal with in the real world are patients that would probably have been excluded for calcium as the, you know, exclusion criterion. So, you know, in those specific instances, I still believe that the technology works, and I'll show a similar example. But, you know, when you have to address calcium, there's a host of ways to do it. But I think to do it with a balloon-based technology is safer and more efficient. And I think specifically, you know, as Mike pointed out, the serration spikes, you know, we know that pressure is force per unit area. So in the engineering parlance, we would call these stress concentrators. Each of those tips of the spikes are able to penetrate even 360 circumferential calcium and create a fenestration, if you will, which is going to be good for vessel compliance change, elimination of dissection, or at least flow limiting dissection, and for drug delivery. So I think, you know, this is actually a perfect marriage of approaches where you can with a balloon, assure that you have adequate vessel expansion. And then the DRS, even though it's got good radial strength, its main mechanism is to biologically deliver enough drug for long enough to resist restenosis. And as we just saw the 2-year data that Brian DiRobertis presented at Viva, the treatment effect we think is mostly based on the drug, the scaffold to a lesser degree in that group of patients where they weren't very heavily calcified. But I think in this patient population that Mike just showed, calcified lesions, the scaffolding is really important, and you're not going to get a good result if you don't prep properly. So, again, I'll show a case similarly where I don't think other prep solutions would have worked as well. And I think that's really the sweet spot for this technique.
Yeah, and so a lot of interesting points you made. I'll just make a quick comment, then I have another question. But one comment is in terms of the mechanism of action of Serranator, and Michael mentioned this, there are a lot of industrial applications where the way you create a cleavage plane or a stress relief plane is through a ... type of the way you tear a check out of a checkbook or a piece of paper off of a pad. You have a series of what you call, I would say, serrations that allow things to open along that line. And this is, of course, we know this from IVUS and OCT, that this is what happens with Serranator. Also, I noticed, Michael, on both cases, you went right into the foot with Serranator. We always have a lot of hesitation of going into the foot unless it's strongly indicated, because part of the challenge is all we really have down there is plain balloon. And if you get a dissection, you're kind of stuck. So what's been your experience of following the lesion right into the foot using Serranator? You went right into the plantar in both cases.
I mean, I think Serranators are very, very safe technology. I think if I had to take this specialty balloon to a 14 or 16, atmospheres on inflations, I'd probably feel a lot less comfortable doing it. But therein lies the genius of the design, right? It's low pressure atmospheres delivered to a lesion. It's going to be safe. I haven't seen any perforations. I think that dissections that occur with angioplasty usually occur due to the way you cross these CTOs less than the actual inflation of the balloons. And I think going up really quickly is something that's going to predispose you to a bad outcome. So I haven't seen that, and I think that the results from what Ted has been working on, the BTA specialty balloon outcomes using Serranator, are fantastic too. I'm really excited to see those get published.
Yeah, so just briefly for the audience, we're going to jump into the chat for once, just in one moment, but let me just conclude this thought by saying what Michael is alluding to is that we've had pretty major, significant, I would say, clinical study. PI is Ted Gifford. Probably some of you on the call may be PIs. I know Michael's a co-author, and basically it's using Serranator to go right into the foot, to do the pedal loop, to do the plantar vessels, in a way that we don't think of as necessarily quite so safe with the other tools that we have, and just showing that we can get a nice smooth surface with good lumen gain in the foot. So let me, and that's in process right now. So you'll see that coming out in the next few months, and maybe in the new year even we could have another visit and just focus on pedal use of Serranator. So one of the questions from the chat is about what size sheath these go through. So I know what the IFU is, but you guys are experienced clinicians. So, and the question specifically is about what will go through a 5 French sheath. I wouldn't put a 5 by long through a 5 French sheath. Michael, what do you think? What would you put through a 5 French sheath?
So everything up to 4/120 will go through a 5. The Cook 590s will accommodate those. When you get to 5, you got to go 6 French, and certainly with the 6mm balloons, you got to be 6 French. And I would say that the 6mm Serranators may be slightly tighter than the 5s, but they'll go through 6. So 4 and 2.5 to 4 up to 120 lengths, perfect through a 5.
Okay. And then one of my very top-notch partners at UCSF, Chuck Eichler, is asking in the chat, do you have any concern about using this technology in the subintimal space? Let's say you've done a long occlusion, SFA or tibials. What's been your experience so far?
Yeah, no, we haven't had a problem. I mean, I had a recent case where we had to do a reverse cart, which I'll show. And, that's always a situation where you're by definition in dissection planes. And we actually used Serranator to sort of fenestrate and help connect the two lumens after we got the wire across. So again, but I do, I would say that I wouldn't do it blithely. I think if you use IVUS for sure, you'll feel comfortable that you're not really, in the adventitia, where I think you might want to be more cautious. But I think if you're within the architecture of the media, you should really don't need to worry. Again, for reverse cart or cart, any of these rendezvous type techniques, I think it's a useful tool specifically for that because it helps you kind of unify the two lumens, whether one's false and one's true or both are false, whatever it might be. I think it's helpful for that.
Yeah, I mean, I would agree with you. And I would also say that, in the subintimal space, you really don't want to do atherectomy. Not really. The risk is too high. I'm not sure how well Shockwave works in that setting. It probably does, but I don't know. I know Serranator works pretty well in that setting. But anyway, having said that, maybe we should jump into your cases, Sahil. I
Sure.
know you have collected some interesting, ideas and applications around this, and maybe we can come back to DRS while you're
Let's see.
showing yours.
Let me pull up my let's see if I can get them to come up here. Hold on.
All right,
Here you go.
super. We can see
Okay, great.
your screen.
So I want to thank my fellows for helping me out, and we've collected these. We tried really to look at the last few weeks, so most of these are pretty fresh. So I'll try to go through them relatively quickly, and we can talk. So the first is a 68-year-old man, usual risk factor profile, has known atherosclerosis and has typical risk factors. He's trying to quit smoking and drinking, and he's a severe claudicant, and he's got a bruit in the left groin and biphasic distal pulses and an ABI of 0.67, as you can see here. Pretty blunt on the inflow and then worsening as you get towards the outflow. So here's the inflow shot, pretty unremarkable. And for some reason they were all recorded at 1 frame per second. So my fellow put the still frames on the left if we lose patience. Here's the SFA. You can see there's a high-grade proximal lesion. There's a external iliac lesion above where the shot is. High-grade proximal SFA lesion. And then this is where it gets kind of interesting. You get down to this is the level of the pop. There's no named vessel between the pop and the tibials. And I'll show you a better picture of that in a second. Here's the runoff, sort of a reconstituted PT that fills down to the foot. And here's that pop shot where you sort of have a occlusion and then recon of the trifurcation via geniculates. So it's sort of typical day in the life of most of us. So here's a better look at that external iliac lesion, which is going to need to be addressed on the way out. So multi-level disease in a claudicant, but one where I would argue that even though I don't like to treat tibials in claudicants, this is a guy whose outflow is so bad that anything we do upstream is going to be jeopardized if we don't treat the outflow. So we got down and we're able to. This is a sort of a more coned in shot here, and we were able to actually, with roadmap guidance and a Gladius wire, 14 wire with a Navicross, get across this. And you can see here's many views that we took of this, but we're able to follow the calcium strap and get across. And here's from the tibial back. This is the IVUS run. And it's interesting, there's not a ton of calcium. there's just a lot of fibrous plaque. But there's a long segment of it, and the caliber of the vessel in the behind knee popliteal is relatively small. This is now up into the SFA before we get a, sort of a reasonable size vessel. And again, not a ton of calcium, mostly fibrous atheroma, which I was frankly surprised. I was expecting, given his smoking history, that this was going to be a rock pile. But you can see, all the way back to the sheath, there's not a ton of calcium. But so we got across, and we started with a plain old balloon angioplasty. And I've kept the inflation in here because you see that we can profile the balloon, but it's only a 2.5. We're just trying to create a pilot channel. And then really in the area that I wanted to avoid stenting because it wasn't big, we used a Serranator balloon here. So this was a 5x40 balloon, I believe. We really wanted to sort of treat these areas that were heavily fibrotic. And again, so people usually associate Serranator with heavy calcium, but here I really was trying to avoid that section that would require stent because the outflow is not so great, and I'm worried that the sketchy outflow would potentially jeopardize if I had to put a stent in. So again, here you can see the Serranator inflating in a focal lesion up higher in the mid SFA or just above Hunter's Canal, and then in that proximal segment where there's a high grade lesion. And then we even treated, just because I had it in, we treated that iliac lesion with the Serranator. So here's the runoff after that. And so in all areas, we got a pretty respectable result with little dissection. And you'll see again, here's the real-time runoff and here's the still frames. So even in that occluded segment, we were able to get into the perineal and open it up pretty well. So then I came in with drug-coated balloons, and this is a 5, I think 200 Ranger. We basically, this is a 6 200. We drugged the whole thing. And then after the DCB, I got a dissection in that proximal SFA, which I had to treat with a self-expanding stent. And then we also treated the external, and this is the final result. So again, we avoided stents in the FemPop by and large. And then in the tibial runoff where, again, normally I wouldn't treat tibials for claudicants, but here I think without runoff, anything you do upstream is jeopardized. So we got single vessel runoff to the foot. And here's his last pedal shot. And he's collateralizing his PT. And here's the final of the external that we'd stented. So, again, here you don't associate plaque mod with or vessel prep with fibrotic lesions, but if you're really trying to avoid metal, I think that, again, here the Serranator was my choice. Peter, I'm just going to keep going. You can stop
Sure.
me if you feel.
Yeah, no, there's lots to discuss, but we'll kind of mix and match. Why don't you go ahead?
Okay, so this is a case from last week. Some of you, I've been out with a cervical disc, so this was one where I got to play Monday morning quarterback from the control room, and one of my new faculty, recent fellows, did this case, and so it's a 70-year-old woman, multiple risk factors with CLTI, with a wound on the right big toe. She's a dialysis-dependent renal failure patient, and has non-compressible vessels. Inflow is pretty clean. And Prox SFA is pretty good. There's mild disease in the mid vessel. Another mirror image patient of what we just saw, no named vessel at the level of the distal SFA P1, P2, and just geniculate collaterals around the knee. Recon of the perineal and a little bit of the PT, and then the AT distally. So here's the foot. And again, the flow is quite sluggish. Her wound is on the first toe. So really the AT is a dominant angiosome of interest. And so this was one where here's the occlusion until you get to the perineal. You don't really see the AT coming in well in this shot because it comes in much lower towards the distal third of the ankle. So, again, I encouraged them to to try to wire it, and they were unable to wire true lumen antegrade. Now, and this is where we did the reverse cart. We actually wound up having to reverse cart in the behind knee pop. Usually I try to do that in the AT, but we weren't able to get the true lumens to connect in the AT. So we had to stick retrograde in the AT just above the malleolus, and then come retro. This is a V18 retro with a command antegrade and just a 4.0 conventional balloon to get reverse cart. So then in the tibule itself, we did sequential inflations with the standard balloon. And here, after doing conventional balloon angioplasty, we had a pretty significant dissection. So we came back with Serranator to, as I said before, to try to connect the two dissection planes more evenly without sort of a linear dissection visible. And so here's the result, which I was frankly surprised that we didn't have more dissection there, especially because we'd done reverse cart right behind the knee.
Yeah, it looks great.
Yeah, it was pretty. So here's another view of it. I told him to keep taking pictures because I was going to use it for this talk. And you can see that we got a pretty good result. There's still evidence of dissection, but on IVUS, it was not flow limiting. And in the retrograde sheath, we all of a sudden got a booming pulsatile blood flow with a good pressure waveform. So, what you see down here is that there's a fair bit of dissection, which we actually then went back with Serranator to kind of clean that up. And so again, a couple more balloon inflations there. And now here's the final result. After 2 more Serranator passes, we thought about scaffolding this patient, but she's new to the practice. We weren't so sure about her compliance. Dual antiplatelet is really important for people who get a spree. And I wasn't 100% confident because we just met her for the first time, and we thought we got a really good result. Here's the foot shot at the end, which we thought was substantially better, and we thought would perk up over the next couple of days. So another example of how we use Serranator here really to help connect the dots, if you will, to connect the two lumina from above and below in a reverse cart rendezvous situation.
Yeah, nice result. I was going to say that it's interesting how the anatomy of the popliteal artery on the first 2 cases looked really similar with an
Quite
occlusion,
similar,
and then
but we got lucky the first time. We got true to true, but we're not always that lucky.
yeah, I was going to say that's what retrograde access, that's almost where it works best, where you have almost no other option when you're
Right.
trying to get antegrade through a popliteal occlusion. You got the wire wants to go in every one of those 40 little perigenicular collaterals, and you just can't find the spot. The other thing that I thought was so this patient you just did recently, so you've got to wait to see. Well, do you think she'll need a toe amputation, or
Yeah,
is
so
that not a full thickness?
It's interesting. So we kept her overnight because she was a dialysis player and needed dialysis the next morning, and she was rigering, with evidence of sort of pedal sepsis brewing, and she actually became bacteremic after revasc. So we wound up giving her systemic intravenous antibiotics, and she cultured staph, methicillin sensitive staph actually. So the podiatry team has seen her, and she doesn't have any fluctuants, but on MRR she has osteo of that toe. So she's going home actually tomorrow with a plan for 6 weeks of antibiotics. Everything's settled down systemically. She's not sort of looking septic, and there's no pocket. And the jury is out. She's going to lose her nail for sure. Whether she loses the toe or not is sort of open, but she's made substantial progress just in a couple of days. We did the case Thursday, and she's going home tomorrow.
Interesting.
So the jury's out. I think, I'm not sure we'll save the toe, but I'm hopeful if, because she's going to get antibiotics at dialysis. And we've learned in the last few days that she seems pretty compliant. So we're hopeful that, we'll be able to salvage the toe.
Great. Michael, any comments on these 2 cases?
No, I think that there's something in the water in New York City if everyone's showing up with those PT occlusions. I saw both of those cases. I get excited because I think that those cases are really fun to do, just because of the challenges they pose. And 50% not having to stick the foot to get the results you got is pretty wonderful. It's a great application of the technologies you use.
Yeah, I mean, look, there's no dearth of patients, let's say that, in New York. And these are sort of emblematic of the types of folks that we see. I think that we are always looking for sort of more straightforward ways to manage them. I'm not a big atherectomy user. I don't practice in an OBL environment. And so we are looking for ways to treat vessels without, sort of complicating things. And a balloon-based strategy certainly speeds up the case. It's more consistent with our usual workflow. We've found Serranator to be very much a valuable adjunct. So this is another interesting patient, another dialysis-dependent renal failure patient, more typical of our practice. It's got multi-vessel PCI because it was not a cabbage candidate, and has osteo with both popliteal disease and tibial disease. And it had PTA at an outside hospital, but had persistent poor healing and progressive symptoms. So really the crux of this case is that the patient has nodular calcific disease of the posterior tibial artery. It looks like there should be adequate perfusion of the foot, but the Doppler waveform is monophasic at the PT despite what you see here. And so right in this mid segment, it turns out it's all heavily calcified nodules, which we find in coronary intervention and also in peripheral intervention to be sort of the most vexing treatment. So here's the image on IVUS. This is pre, and what you see right here, you see that there's all this dropout. There's a big protruding nodule in the vessel, and it had been angioplasty. Here's another one. This is, in the coronary parlance, we call these eruptive nodules. And these are the highest propensity for failure in coronaries, and I think probably in tibials. We're sort of working on a manuscript where you see these eccentric nodules of calcium tend to cause a lot of difficulty. I'll come back to this IVUS in a second, because what we did was we actually used the new E8 shockwave, thinking that we'd try to disrupt the calcium. We got okay luminal gain, but not satisfactory. So we came in with Serranator to follow. Yes, it's an expensive case, but this is a patient who's already failed once, and we felt that we had to really give him a college try. So IVL first with the E8 3.0, and then Serranator 3.0. And then this is the angio afterwards. Still got some sort of nodular calcium, but we think we got better vessel gain, lumen gain. So here's after we did all that, we wound up putting in a couple of Esprits at the site of those nodules. And you can see that the lumen, even though it's not perfectly circular, is much bigger. And I'll show you the final angio. And only time will tell. This was also a case we did Thursday. We were busy. Here's three overlapping Esprits. Here's the final angio. Proximal area was non-obstructive by IVUS, and here's the mid segment that was scaffolded, and here's the foot. And whereas before we only had a monophasic Doppler, even though the angio looked good, this was almost triphasic, and it was a palpable pulse. So the patient's symptoms, pain-wise at least, got much better right after this, and he's discharged and will be coming back for follow-up. But so this was a case where we sort of took Serranator after IVL, largely because we didn't feel like we got a good enough result. And we tried to get better lesion prep, and then we came in with a scaffold, hoping against hope that we could prevent a recurrence and get him healed.
And it seems like, let me just ask you just briefly, Sahil, it seems like you're using a lot of IVUS. Is that kind of getting to be your routine now, or
yeah, I mean, I think, Peter, we're creatures of
algorithm.
habit. Coronary guys, we like to use IVUS. In our lab for coronary interventions, the imaging percentage, both IVUS and OCT, is 85%. So it's very rare that we don't use imaging. So we're very facile with it. And then for peripherals, I find, and I don't use OCT for peripheral except for sort of experimental reasons. And on another call, maybe we can talk about that with Serranator. But for the purposes of this discussion, the IVUS, I think, informs our approach in every case. It's either going to change your vessel size estimate, the length of the lesion that you're going to treat, or as in this case, it sort of tells us that we have nodules of calcium as opposed to the typical medial calcinosis that we usually see. And so I think it sort of, we wanted to try something different because the nodules were where the patient had recurred. And that's what we see parenthetically in coronaries and other places in the lower extremity.
And just before you jump to your last case, let me just ask about what you both like to do in terms of assessing hemodynamics. So obviously you can't argue with a palpable pulse, especially in an ESRD patient like this one. My usual is to have some kind of hemodynamics before and after, because we're frequently left with, even though we've done everything we can do, the patient still has a burden of disease, whether it's in the foot or elsewhere. So I like to get toe pressures if I can. We use skin perfusion pressures. We've been working a lot more now with pedal acceleration time. That's another. TCPO2, every tech rolls their eyes because they know it's going to take time. It's going to really put a hole in their day so we only use that very selectively. But what do you have a routine? Maybe Michael, you could go first and say what you do, and then Sahil, you could say your algorithm for that.
Yeah, I definitely try to do the same things that you mentioned, Peter. But I think the unfortunate reality is I rely very heavily on the subjective assessment of my foot and ankle surgeons. And oftentimes it's the text message or the phone call after they've taken the patient that we've asked 24 hours prior to their OR procedure, being like, holy crap, that bled a lot, or like we had to use a tourniquet. And you get that like sick, sadistic sort of satisfaction knowing that your revascularization procedure made their life a little bit more challenging. But in addition to that, just very, very close follow-up with these patients. I'm very lucky to be able to work in a place where I sit next to my podiatrist. So we're able to assess these wounds at a more frequent interval than we normally would get arterial non-invasive studies. So at 2 weeks, we're getting to see them. And, sometimes a Doppler assessment in clinic can be just as valuable as the 1 month ABI toe pressure duplex.
Right. And I heard Sahil commenting on the waveforms, and that's, of course, a very quick way to get some immediate feedback. I don't know, Sahil, anything to add to that?
No, not at all. And I think that it's a holy grail of our field is having a good perfusion assessment, both in real time and then in the office. I mean, we're stuck, most commonly we can get toe pressures. Many of our patients come from satellite offices where they don't have the same sort of sophisticated imaging techniques that we have at the mothership. So, that's usually what we're relegated to is toe pressures and PVR waveforms, and then we'll get a Doppler signal. So those are the things. I mean, I think that would be great if we had more. I think if I have a retrograde sheath, I do take the excuse to get a waveform assessment usually, because we're hooked up to pressure on all of our manifolds because it's a cath lab setup. So that's usually helpful. And there are some data published about retrograde pedal pressures based on retrograde sheaths if you have one, but we don't use that in every case like some places. So it's not something we'd have access to every time.
Makes sense. You want to jump into your next case?
Yeah, I'll just do a quickie here. This is a 73-year-old patient of mine who had CLTI, had Supera stents after shockwave IVL, and then comes back with a lesion subset that we all find vexing. It's in-stent restenosis. So here's the Supera. As you can see that He's got occlusive ISR inside his stents. And these are patients, so we use laser for these in the main, and we use a filter usually. So this is a lot of embolic debris in the filter after laser. And I like to really treat these because I'm going to finish with drug-coated balloon angioplasty, but I don't think that either laser or Jetstream or Rotarex, whatever you use for the debulking, and I'll call it debulking because I think that's what it is. When you're treating these occluded stents, there may be some thrombotic component, but there's almost always intimal hyperplasia. And I feel like appropriate debulking and then lesion preparation is going to set you up for success with a DCB, which is what we did here. So here's this was a 5.5 Supera, so a 5.0 ID. So we used a 120 Serranator sequentially, and then came back in with DCB with a Ranger DCB. And here's your final angiographic result. But it's another lesion subset. I was trying to find sort of discrete lesion subsets that may not just be calcific tibials, which is where I think people think that Serranator is a good device. But, here's a fibrotic in-stent restenosis segment where I think lesion preparation with a serration technique is really good. And we got a pretty good angiographic result. Time will tell if we can keep him out of trouble. And he'll come back for surveillance, on a regular basis. And we'll watch him closely. But symptomatically, he's doing well post-procedure. So that's all I have.
That's a good
Peter,
case. Yeah. I would like to thank Sahil's fellows. Thank you. No, and we all are on a team on some sort. There's just too much to do here. So it's really awesome to have that kind of collaboration and discussion. And in this case, the back and forth that it takes to, they have to kind of know what you're thinking to pull the right stuff. But so a couple of themes came through I just wanted to ask you about. So ISR, I'm in 100% agreement with you. I think this is where quotes debulking actually does make, to me, like I know what that means. It makes a lot of sense. It's full of stuff. It's ugly, hyperplastic thrombotic stuff. I like laser for it also. But that quotes debulking doesn't gain the lumen the way you want. So I can see using Serranator there, and that makes a lot of sense. And then finishing that with DCB, I think also makes sense. So we have more than one DCB now is indicated for ISR. So that's also pretty cool. So let me just back up a little bit. And when I think of the cases in their entirety, there were certain themes here. One is, lumen gain with a balloon-based therapy, either before drug therapy or because there's been some calcific disease, or even could be in combination with, you showed a shockwave case. I did one today where I did directional atherectomy followed by Serranator to kind of, again, gain more lumen, but also to gain it in a way that maintains the theme of atherectomy, which is minimizing dissection, that sort of thing. And then Michael showed cases going into the foot. I don't know, we have just a couple more minutes here. Michael, I don't know if you want to just give a little bit of technical tips about the foot. Do you use the same wire, different wires than you use in the straightaways of the tibials? Do you have any kind of change, because now you're using the Serranator going around corners, and of course we do that in the proximal AT and other places, but the pedal loop is, more curved. And so I don't know, do you change the way you inflate the balloon? Are there any other tips that we should be thinking of for angioplasty using Serranator in the foot?
I think that, the big take home for using these shorter Serranators or smaller Serranators, you've got to prep them effectively so you can see them fill. For the most part, they're very easily delivered, especially using the 2.540, 2.5/120 is very, very easy to deliver. And once you effectively prep it, when I prep these, it's 3 negative pulls outside the body on the sort of inflation sort of port with a 50-50 syringe of contrast. And then, I don't really use it on the way the IFU describes. I want to see parallel lines in my inflated balloon at the lowest possible pressure. So if I have parallel lines, meaning the balloon looks like it's effaced at 2 atmospheres along the entire length of it, I'm not going to take it to 6 atmospheres. I'm going to take it to 2, maybe 4. So I think, again, just the strips of metal allow you to get predictable results at low pressures, irrespective of where it's used in the body.
Hey, Peter, I think you're muted, buddy.
Yeah.
Oh, thanks. Yeah, we have a couple questions from the audience, and one of them is about below the ankle work. And I know my answer, but since I got the world's experts here, let me ask you guys, what ACT do you use when you're doing below the ankle work, and how long do you leave the balloon inflated? I'm assuming that means how long can you leave the balloon inflated, but also, not just for efficacy, but avoid complications. So ACT and timing on balloon inflation.
So we're coronary people, so we run ACTs on the high side. So generally we don't do anything 250 or less. And if we're doing complex coronary or complex peripheral, we're sometimes bumping up the ACT closer to 300. So with the patient that anticoagulated, usually you can do prolonged inflation with no trouble, particularly if you're not occluding all the vessels or collaterals into the segment. So, again, I think that, I don't know if you have a different opinion, Mike, but again, we are a little bit informed by our coronary experience. And so we tend to bump the ACTs up also if we go retro. So we find like, if we're going to use a 4 French, let's say a Pinnacle Precision or a 2.7 Cook retro kit, we'll bump up the ACTs to well over 250 to closer to 300.
Yeah. Michael, anything else on that?
I don't routinely check ACTs for my cases due to the wild inconsistencies of ACTs.
Yeah, interesting.
Regardless of which hospital or which OR or ACT machine we're using. So I'm pretty just standard with the way in which I heparinize. And, I'm knocking on wood right now, thromboses and seeing the development of clot isn't something I routinely or really ever encounter when I'm doing peripheral interventions that are, for clot. So knocking it on wood, but yeah, not too worried about it.
Good. Yeah, and just to make it 2 against 1, I go for 250 when I'm doing work in the foot, because I'm, I have this idea that I can inflate the balloon for 3 or 4 minutes if I want to. That's my thinking anyway, because part of the question was how long do you or can you leave it inflated? Yeah. Let me ask you, we got a couple more questions from the audience and only a couple minutes left on our evening seminar. But one is, and I'll ask you, Michael, what's your algorithm for inflating the Serranator? How fast do you go up? How many atmospheres? When, you go up a little bit and stop? What's your formula?
Get the balloon to where you want it, hook up, then go up slowly. So I go up maybe, 1 to 2 atmospheres every 5 to 10 seconds. And I'm pretty satisfied with the amount of atmospheric pressure I've delivered once the entire balloon looks like the lines are parallel and there are no wastes. Now, when I'm dealing with a lesion that requires a little bit more oomph to address those, resistant areas, I'll go I'll continue to go up very slowly. So over the course of 20 to 30 seconds, I'll maybe take it to 6 or 7 atmospheres if I need it. And it's very rare in the arterial space to need to take it much higher than that to get the walls of the vessel to be addressed.
Yeah, that makes sense. I mean, in all the studies we've done so far, it appears that the balloon does its job at a lower level of atmospheres, which is consistent with this point force concept and this the fact that there's more pressure exerted at the tips of the points. And then Sahil, there's a question here from Dr. Jeff Martinez about when you go into the foot, you know, he's mentioning mostly having used 2.0, you know, kind of balloons. Would you use a 2.5 in that setting? So in other words, really your sizing. How do you decide your choice of sizing for going into the foot? Obviously, we're making this up, right? Because
Completely. That
it's
was what
not
I
an
was going to
easy
say.
place
Yeah.
to do IVUS. And so
Yeah.
what's your formula? What do you usually think of?
It's completely made up. I think that some of it's predicated on how big the tibial vessels are. If I have big tibials and I'm, you know, dealing with like a lateral plantar or medial plantar, then I'll go maybe 2.5. But more often than not, I'm with Jeff that I would do 2.0 first, and I might stepwise go up. The dorsalis is the biggest I've ever done in a foot. I think mostly it's 2.5. Occasionally it's, you know, as you know, if you have a tapered balloon like Mike showed, that's actually a nice application of that. You bring that around. But if you're going around the loop, I'm awfully careful because I don't want to prune those smaller vessels that are actually feeding the digitals. So I think, especially if I'm totally not confident about my wire course, I start small and I usually upsize if I feel like I need to. I don't know that there's any rules. There's no easy way to size them other than, you know, using a balloon and seeing how it profiles.
Yeah, Michael, anything else?
No, I think I'm a little bit
Anyway,
more aggressive. I think at 2.5 and 2, there's not that big of a difference between it, especially if you're taking a very low atmospheric pressure.
yeah, and if you go to low atmospheres, I think that's the key, and that's also what Jeff Martinez was asking. You know, just could you go a little bigger but go to a little lower atmospheres? And I think that's my experience says that's totally reasonable. Anyway, we're at the hour. I'd like to thank Dr. Mike Siah, Dr. Sahil Parikh, two big stars in the area. Everybody stayed on for the whole hour, which is awesome and amazing. I highly suggest that everybody take the rest of the day off if you possibly can. And I'd like to thank everybody for joining us. It's really exciting. And I think we're going to talk more about going below the ankle, maybe in the next edition of this webinar in the coming months. So thank you very much. Thanks to the audience, and have a good evening. Night.
Right.